Hello and welcome to Single Payer Radio. I'm Paul Hoppe, broadcasting from the Hayburn Building in Louisville, Kentucky, on the WFMP 106.5 Forward Radio Community Network. Our programs air every Monday at 2 p.m., Tuesday at 7 a.m., and Wednesday at 11 a.m. And we also stream our show on SoundCloud. The show is a project of Kentuckians for Single Payer Healthcare, affiliated with Physicians for a National Health Program through its Kentucky chapter. We produce this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, publicly funded, single-payer healthcare system for everyone. The views and opinions expressed on our show are those of the speakers and not the station. Our station relies on volunteers like myself and your ideas and donations to keep us on the air. Today, Doctors Mike Flynn and Jean Shively join me as co-hosts with their guest, Dr. Don Henderson, with more discussion on private equity in healthcare. Mike?
Yeah, this is Michael Flynn, retired surgical oncologist from the University of Louisville. Let me begin with the usual disclaimer that any comments I make are my personal views and do not represent the views of the Department of Surgery or the University of Louisville. Our topic today is private equity in healthcare. Now, this is the third program we've done on this. Jean and I have done two programs on this, so we have a special guest today, Don Henderson. I'm going to let Jean introduce in just a moment. Before we do this, I just would like to challenge our listeners that there are multiple information sources available to double check the facts that we are and the comments that we're going to make today. Whether you go on Google, a podcast, I would recommend a book written by a nationally known author, Gretchen Morganson, called These Are the Plunderers, How Health Equity Runs and Wrecks America. So, Jean, after you've introduced Don, we'll give him an opportunity to make whatever comments he'd like to make for as long as he'd like to make them, and then the conversation will begin. So I'm going to let you do the introduction.
Okay, first I need to say that my comments are those of mine and not those of the Taylor Regional Hospital in Campbellsville, Kentucky, nor are they represent the University of Louisville or the Department of Surgery at the University of Louisville. Don Henderson is a cousin of mine. He's been involved in multiple hospitals throughout the Southeast as an administrator, both rural and urban. And he's now has a doctorate degree in hospital administration, and he teaches in Florida. Don, why don't you tell us a little bit more about what you've done in your career and your education and what you're doing now, and then we'll get a little bit started on private equity.
Okay, well, thank you, Dr. Shively. Yeah, I have a doctorate in healthcare administration. I'm currently a full-time professor at the Lake Erie College of Osteopathic Medicine campus here in Bradenton, Florida. But I also want to give the disclaimer that these are my opinions only and do not reflect do not reflect as official comments from the university. I was prior to being a professor, I was a hospital CEO for over 30 years and worked primarily in the southeastern portion of the United States, and especially got to observe a lot of rural healthcare as I was in the process of managing several hospitals in that setting. So I think I have pretty good understanding of private equity healthcare, and also have actually disclosed that I've actually worked for some private equity healthcare companies, or else companies that owned for-profit hospital chains. So I have pretty good experience in all those areas.
Okay, that's great. Why don't we just start out? How do you define a private equity company?
Yeah, well, it's a little bit. If you look at the hospitals in the United States right now, start with hospitals, and we can talk about physician practices after that. But if you say that there are approximately 4,500 hospitals, community hospitals in the United States, about 1,000, a little over 1,000 of those, or 25-30%, are owned by for-profit companies, and of those, the latest figures are that 386 hospitals are owned by private equity companies. So about a third of the for-profits, which in turn, the for-profits are 30% of the hospitals in the United States right now.
So how would we separate a for-profit hospital versus a hospital that's for-profit that's owned by an equity company? And then I got another question: are there not-for-profit hospitals that are involved in equity companies?
Yeah, I think the difference between the equity players and the regular for-profit hospital operators, there could be some for-profit hospital. I know some of the rural hospitals are actually owned by families, and that's a small percentage. But beyond that, the regular hospital companies, for-profit, are publicly traded. So in my career, I worked for two of the publicly traded. So the equity is in the shareholders, but the private equity firms are usually closely held by just a few principals, and it's a much more a smaller group of ownership.
Now, Don, let me explain my understanding of the private equity situation. My understanding is this is a leveraged buyout. Blackstone, other companies like that, with billions of dollars, will acquire a facility. There's a hospital, an emergency room, a healthcare system, and they put up about 25-30% of the equity, and then the other 70-75% then is the debt collateral, which becomes whatever the facility is, whether it's an emergency room or a hospital. And then their goal is to, quote, improve efficiency, unquote. And I'm putting that in quotes because there's some questions about the impact of that. And then they would run this for a period of years, and then 4 or 5 years down the road, they sell it and move on to something else. So, this is not meant to be a long, happy marriage. Now, is that a fair understanding of the circumstances of private equity in healthcare?
Yes, and there are any number of firms. There's one private equity company called Apollo Management that has the largest share of these private equity hospitals. And yeah, I think that what you said generally is accurate. There's also, we forgot to mention this, but there's also right now, according to the statistics that I saw, somewhat less than 1,000 physician practices, and that's an emerging trend, and especially single specialty physician groups, for example, orthopedics, are being bought by private equity firms. But that number is something around 1,000 practices in the United States right now.
And now, when you look at their strategy, which is, quote, improve efficiency, unquote, that generally means that they are going to reduce the staff. The biggest cost of running a facility, and there's a lot of inequities and inefficiencies in running hospitals and healthcare systems, but they come in and they end up with, for example, I was reading this story about emergency rooms in which the main cost of the emergency room is a qualified emergency room physician. So instead of having a bunch of emergency room physicians, they decrease the number of emergency room physicians and hire nurse practitioners and medical assistants, physician extenders, who don't cost as much. But on the other hand, the data shows that they do more tests, they have more difficulty making diagnoses, and the cost to the patient is higher. But since they've reduced the cost to the management of it, that's where they're making their profit. Again, is this, from your understanding, is this a fair statement of some of the consequences of how private equity works in that particular situation? I've got a number of other examples we can talk about.
Yes, I think the emergency room is a good example. I would say the largest expense for most hospitals is the nursing staffing. And there's no question that for-profit and private equity companies reduce the levels of nursing staffing. Usually that's measured on a per-patient day. And there's no question that they are very frugal with that. When I used to work for for-profit companies, they used to change the nursing staffing levels about every 4 hours, which obviously is going to result in some people being sent home early, et cetera, et cetera. So that's one of the things they do, is they're very tight on staffing. They also, monitor the use of supplies and equipment judiciously to try to save money there. Some of the other things that they do is they eliminate non-profitable business lines. One of the biggest ones that's creating consternation in the rural areas is the elimination of obstetrics services at the hospitals. We can talk about that if we want to. They streamline billing and collections procedures, and they're much better at collecting than many of the not-for-profits are, and they get some juice out of the lemon doing that. And they also open new profitable business lines such as elective procedures and diagnostic equipment. So there's a whole armament of things that you can do to improve hospital margins. And of course, rather than investing all that back in the community like the not-for-profit companies do, they pretty much take as much as they can to make their investors happy.
And this is basically a fundamental conflict of interest between providing care and extracting profit out of healthcare.
Well, it can be depending on the practitioner. One thing, I don't know if you all in one of your other meetings quoted this Harvard study that came up in December of last year, but that's where the folks at Harvard and the Journal of the American Medical Association tried to see if there was an actual measurable difference in the quality of care between private equity-owned hospitals and other hospitals. And they determined that the rates of things going wrong, things like patient complications, hospital-acquired infections, and other negative outcomes, patient falls, for example, that the rate of these were much higher, 25% to 45% higher. Remember, that's just the rate. That's not 25% of all patients. Maybe it's 5% of all patients. So the rate is much higher at these untoward events. And some of that is also driven by staffing, because if you have less staffing, the nurses become more rushed. They don't have as much time to watch the patients. So all that could result in a decrease in the quality of hospital care.
Yeah, no question about it. And this was a study that was done based on 100% of the Medicare Part A claims in 600,000 hospitalizations in 52 private equity acquired hospitals. And that data was compared with 4 million and change hospitalization in 259 matched hospitals that were not private equity acquired. And this is just one example of many other examples of the negative impact on healthcare by having a healthcare facility owned and managed by a private equity firm. It's really scary.
It really is. I want to ask a question about groups like orthopedic surgeons, urologists, and other large groups, dermatology and ER. Why do they get involved in this? And let me just give you a couple anecdotes. I know a couple of physicians who actually done this. They've sold their practices, and the reason they did it was because they didn't have enough equity and capital to manage their practice, and the paperwork and the bureaucracy was getting so overwhelming that they just didn't want to do that anymore. Is that an accurate assessment of why most physicians are doing this?
Yeah, I've talked to some of the folks, or some of the doctors that work in the equity-owned practices, and I think a big part of it is what you pointed out, Dr. Shively, which is the less burden of paperwork and administrative costs, and obviously less risk because it allows the physicians to practice medicine without worrying about the administrative side of things. What the case that's made for private equity that they make to the physicians is beyond the improvements in their quality of life because they don't have to do all this administrative work. They actually claim that they can find a way to make more money for the practice itself. So usually that's done either through improved billing and collections processes, but it's also done through acquiring passive income streams. For example, and I'm not going to name the group just protect the innocent or whatever, but most of the physician-owned practices that are owned by private equity firms almost always get a surgery center, a captive surgery center. Interesting right now because with the developments of technology, hip and knee replacements can be done successfully in an outpatient setting when they couldn't be done that way only a few years ago. So part of the case for bringing in physicians is that it's like you mentioned, Dr. Shively, they have a lot of equity, and then they can buy these ancillary facilities, whether they be surgery centers, procedure centers, diagnostic centers, and then the private equity firm can then share in the revenue, the enhanced revenue that the physicians can get as a larger group practice.
Now, it was my understanding from some of the information that I've found is one of the issues is once the private equity company controls the practice, they start encouraging people, physicians, to see more patients so that they're packing them in with basic time frames and seeing somebody in 10 or 15 minutes as opposed to being able to go in there and spend as much time as you need. See if you could go into one patient and spend 10 or 15 minutes in there, and another one would take 45 minutes just because some things are more complicated. Also, my understanding is that they do upcoding, and they encourage the staff to upcode as much as possible and provide bonuses for in a dermatology practice to do more biopsies or Botox or other things like that. So it really changes the whole focus of medicine from healthcare instead of doing things that just make more money.
Yeah,
Am I missing something here?
Well, I'm familiar with an urgent care center in a freestanding emergency department company that I won't name their name again to protect the innocent, but we in one of the towns I was in, if you do an urgent care visit, we have urgent care centers, and our private equity competitors had urgent care centers. Our our average billings per patient was something in the $110 to $120 per encounter. Well, it wasn't unusual for our private equity competitors that ran the urgent care and emergency walk-in business to get tickets of $200 to $300 on average for that same patient. So the question is, why are the billable charges much higher at the firms that are private equity firms? I don't think it's appropriate to say that they're upcoding illegally, because that would be illegal, and probably the federal government needs to be called at that point. But you could certainly legally code up as long as there's a viable reason for doing it. And patients would come back to us at our hospital and say, well, why is it that the visit at the urgent care center cost me $250 where you're charging us only $110 for the same visit? So I think you have to draw your own conclusions from there.
Well, again, there's a lot of upcoding that has to do with things that are going on with your body that really aren't health issues. They're just part of getting older or whatever. And if you go into an emergency room or an urgent care center because you've got a scratch on your arm, and they put a bunch of codes in because you're diabetic and obese and have obesity, that doesn't have anything to do with the reason why they came into the urgent care center in the first place.
You're absolutely right about that, but there's something interesting in the way the computer systems are set up that they automatically upcode those things. For example, there are some companies that just take a diabetic, and they will have questions in there about arthritis. They have questions in there about peripheral vascular disease, and almost everybody elderly has those diseases. You can take a diabetic and do a test called a QuadFlow, which is a test to see if somebody's got peripheral vascular disease. And almost everyone's got atherosclerosis if you're in your 80s or 90s. And so you can do a test that shows you got mild peripheral vascular disease that doesn't really need to be treated except for exercise and maybe a baby aspirin. But that changes the amount of coding and amount of money that you can get from the insurance company and from Medicare and Medicaid. And sometimes the computerized system just kind of does that on its own if you answer the questions that are requested. So, if you go to the doctor's office now and you got a URI, they don't just deal with that. They got all these things programmed in the computer, and then they'll include that into the final bill for you seeing a patient for a runny nose.
Again, the whole purpose of this is to extract more money out of the healthcare system. Doesn't have any focus, anything. The reason why someone comes in to have a problem addressed, and then these are all add-ons onto that are not the purpose of the visit in the first place.
They're right, and that's routine now.
Yeah.
And you got to realize that our Medtronic medical records are designed for billing, not for healthcare.
Absolutely, you're right. Don, let me ask you a question about nursing homes. It's my understanding that a large proportion of the nursing homes in this country are run by private equity firms.
My understanding is 70% approximately.
Is that a fair statement?
Yes.
Now, I'm going to tell a story. Now, this is, again, and for our listeners, don't take my word for this. You can just get online and go to Google or whatever you go to. There's a nursing home somewhere around Tampa and there was a patient in the nursing home. It's run by a private equity firm, and they reduced the staff. And there was a patient in there who had a decubitus ulcer. And again, for our listeners, this is an ulcer usually in the lower part of the back of the skin that comes from allowing a patient to lie in bed on their back without being moved. and this was contaminated by feces because they were not cleaned. They were laying in bed with a fecal-filled diaper, and they got an infection and died. The family was understandably distressed with all of this, and they hired an attorney to determine who was responsible for not providing this patient with decent care. And they ran into a nightmare administrative structure. One company owned the building. A second company had the license to run the nursing home. Another company provided the professional staff, and another company provided the custodial staff. And they were never able to identify any sort of sense of responsibility. And this is really awful when you think about the goal of extracting profit to the extent that people in the nursing home population, it's my understanding, again, and I'm asking the listeners to double check this themselves, that the death rates are higher by 10 or 15% in nursing homes run by private equity firms. So Don, are you have any familiarity with this, or any comments or about what I've just said?
I don't have any direct familiarity with it, but I ran a hospital and a nursing home together for several years and had some experience as a nursing home executive. And, the unfortunate thing about healthcare in the United States right now, as far as long-term care is concerned, is that it's largely a pay-and-play scenario. And one of the things I learned after I ran a nursing home for several years is that many of the higher income individuals have access to private firms that have a high level of staff, that have great amenities, and they largely pay out of pocket through maybe some insurance they have for this top tier of long-term care, whether it's assisted living or nursing home care. Then you have situations where patients run out of money over time. Most people don't have huge amounts of savings to be able to, pay for extended care. So families run out of money, and then they become wards of the state. It's a very depressing scenario because you basically have to exhaust all of your resources before you can qualify for what they call Medicaid reimbursement. So many facilities are high-end, and patients pay thousands of dollars per month to stay there, and usually the care is good, whether it's for-profit or not-for-profit. Where you get into trouble is where many people run out of resources, and then they have to go to a facility that's largely paid for by Medicaid. And Medicaid reimbursement is almost less than cost. When I was running a nursing home in Pennsylvania, we had pretty good reimbursement, which was in the $250 to $265 per day per resident. But in many places in the South, the state sets Medicaid nursing homes rates very low. And so what results from that is the almost imperative to cut corners in order to keep the facility going. So it is a very tragic situation, and it is totally related to those people that are become recipients, and they have nowhere else to go. So the nursing homes have to survive on whatever money the Medicaid program will allow them.
Now, is this an issue in other first world countries? I don't know the answer to this. That's why I'm asking the question, because it's my understanding from the little experience I've had out of the country that most other first world countries don't have the same issues that we have about profitability in healthcare. Most other first world countries have got a system that provides some kind of insurance, usually government run, that allows all of the citizens of the country to have at least some access to health care. Whereas in this country, we've got, 30 or 40 million people who don't have health insurance. I'm not sure what the number is, but it's a lot. And the other issue in this country is medical debt and medical bankruptcy, which are issues that, again, to my knowledge, are literally non-existent or occur in such a small amount that they don't represent anything close to the impact that they have in our country. We have 100 million people in the United States with medical debt, and somewhere between 200 and 800,000 a year filing for medical bankruptcy, which was the main cause of people filing for bankruptcy in this country. So again, I'm asking the question because I don't have a lot of experience with that in other countries. I was wondering if you've got any thoughts about that, or whether you've had some experience either directly or indirectly with some of these issues in other first world countries.
Well, I think it goes back to, the policies of these different countries. And yes, I don't necessarily have direct experience, although I was in the Middle East for a couple of years, but I've studied all this as part of doctoral studies. And it all gets back to the healthcare policy for the country. For example, if you ask me today, even though I have a doctorate in healthcare administration, what is the national policy of the United States with regard to healthcare and providing basic healthcare for its citizens? And if you ask a politician that, which I have at the federal and state and local level, they'll just shrug and say, well, we want to minimize the cost and maintain the status quo. So the difference between the United States and other countries is that there is a national health policy. For example, in the UK, there was a physician-led effort to update the national policy goals for the health system. And I think that's where the difference is. Our system is, yes, there are many patients who either don't have insurance or the national health insurance doesn't allow them to get access to care, especially specialty care. So getting back to this nursing home example, in the UK, in the United Kingdom, for example, there's a tremendously developed home care system, because I would argue it's better and cheaper to care for elderly patients in their home, if at all possible. And the UK has a goal to do that. They've set up the funding to do that. So all this argues for, a national policy and goals of the system, which the UK has national goals, and then the funding is directed towards the achievement of the goals and not necessarily given to for-profit operators, if that makes sense to you.
Gene, there's a retired surgeon from Louisville who many years ago had some visual issues. He retired from general surgery and was elected to the state House of Representatives. And about 20 years ago, he gave a talk at the Louisville Surgical Society. And, there were two messages I remember him taking away from him. And one was something we've all heard multiple times before, that, making laws is like making sausage. And the other thing he said, and was very clear about this, is the politicians do not understand healthcare. They run construction companies, they run golf courses, they're lawyers, and have a whole bunch of other professional backgrounds. And the time that he spent in the legislature, it was very clear to him that they really don't understand the issues of healthcare. And some of the laws that have been passed in different states to dealing with abortion are a perfect example how correct he was about that.
I would just like to point out that most people don't know who owns these nursing homes. For example, in Campbellsville and the surrounding area, I didn't know till about 2 years ago that all the nursing homes in our area were equity owned except one, and I had no idea. It's just really amazing what's going on. The other thing I wanted to bring up is I understand that one of the tactics of equity companies, let's say, for example, a large equity company goes in and buys a large hospital in a big city, and the property's worth quite a bit of money. Well, they'll sell that property to someone, and then the hospital and the practitioners have to pay rent to the people who own the hospital and the property. And then I know that there's been several instances where the hospital and groups of practices that have done this kind of thing went bankrupt because of the excess rent they were having to pay. It's just a device that equity companies can do to increase their income.
Yes, I think you could definitely acquire and then sell off the intangible assets of the hospital to a third party. And like you said, that creates cash flow, which hospitals have a lot of cash flow, especially if they're larger. But the problem is that it creates a debt, and then that debt has to be repaid. No hospitals can operate without paying their debt first. And of course, if it's too large or there's too much of a debt burden on the hospital, then that becomes a major operational issue, and it can lead to bankruptcy if there's a downturn. That's happened mostly in the rural. There's two classes of hospitals that are really in trouble in the United States right now. One is the general rural hospitals as a whole, especially in smaller rural areas, tremendously under stress. And the other is the inner city hospitals. There are many inner city facilities that have been taken over by private equity firms. And the whole idea is back to what Dr. Mike had previously said, which is they call it pump and dump is the term. So the whole idea is you pump up the revenues, you reduce the expenses, you take a very short-term 3 to 5 year view of that. Then you show a financial statement that has improved operations, which increases the multiple of 4 to 6 times the annual earnings that can be acquired, these facilities can be acquired for. So if you're unscrupulous, you're trying to get a return, which is, I guess, reasonable. But if you're unscrupulous, you can inflate the price, and then when you sell to the new equity person, then they find out they've bought a pig in a boat. They've bought an asset that's really not sustainable, and that's why many of the rural hospitals and the inner city hospitals have gone out of business with these private equity firms.
Well, let me, since I'm spent my whole life in a rural hospital and you're familiar with our community, what are the solutions for rural health care in America?
Well, I think that there has to clearly be some outside assistance. And, that's when I go back to talking about health policy. What is the health policy of the United States when it comes to maintaining rural health care? Years ago, during the Carter administration, there was a plan to create regional health planning agencies, and they persisted for 10 or 20 years after President Carter left office, but they all died by the wayside. And so whether it's at the federal or state level, there has to be planning for rural health care, and there has to be resources allocated to determine what the policy should be, what kind of facilities should be built to serve rural communities, how are we going to recruit the providers there's got to be assistance to recruit the physicians and nurses to these communities to maintain them, because without physicians, no rural hospital can exist. So it has to be a number of things done, and I just am not very optimistic that that is at the top agenda of the country. Now, what will happen, which I think I talked about during the last podcast, is that many of the safety net funds that are funded by private donations are going to run out of money in the next 10 years. There's a growing population of Medicare recipients. A few years ago, Medicare only had 40 million, but by 2030, with the baby boom, it'll be 80 million. The Social Security funds are running out of money. The Medicare program itself, which is funded by the tax on everybody that's working, that program is scheduled to run out of money in 10 years. So my belief is that politicians will continue to kick the can down the road until there's enough of a crisis. Politicians will have to act, and at that point, it might be good to talk about a national health policy and a single payer system.
I think you're absolutely right about that. Other countries have worked this out. Australia has a Department of Rural Health that focuses on providing all of those issues that you've mentioned to the Australian outback. And UK is also with their system, which is, they're no perfect system, but that also deals in an appropriate way with rural medicine in Scotland, England, and Wales. So I don't know. We'll see what happens. Now, Gene, one of the first things that I learned from you when we found you wandering around in the library right behind us, and you came up to that meeting and showed us the data on that 1/3 of the resources in healthcare is not provided, does not go for healthcare. I mean, and that's a serious issue. And what we're talking about today, with all the for-profit issues going on in healthcare, private equity is just going to make that all a lot worse. And Don, you're absolutely right. I mean, I don't know how far down the rabbit hole we have to go before something is going to get done about this. We are on this radio program sponsored by an organization that is promoting Medicare for all.
I don't think anything's going to be done in the next few years.
No, I agree with you.
And I think that it will end up in a crisis. Don, what do you think about a system like they have in Australia, where they have the government insurance, and then there are a certain group of people who can buy private insurance? I spent about 3 weeks in Great Britain on a tour last year about this time, and about half those people were from Australia, and so that most of them have private insurance, and then there is a system where about 2/3 of the people have a government insurance. That seemed to work fairly well in Australia, but I only have the anecdotal experiences of the people I talked to.
We've had Ted Young, a surgeon from Hamilton, Ontario, on the program on 2 or 3 occasions, and talked about the Canadian program. Both Australia and Canada established their healthcare systems in 1984, and again, no perfect systems, but they both seem to be working pretty well, and they don't have all of the issues that we're dealing with in this country.
I think some of the best systems that have been designed, it's very ironic because many of the systems in the Far East are based on the American system. And it is ironic that, for example, Taiwan, for example, their the government leaders came to Harvard and actually started working with a professor there who was very knowledgeable and also came from the same ethnic background. But they took a clean sheet of paper, they designed their system, and I think it's working very well. What's interesting about the Far East, many of the countries in the Far East, is that healthcare has remained private. 90% of the hospitals are private, 90% of the doctors are private. Doctors own hospitals in many parts of the Far East. So even though the providers are private or free enterprise, there's a national health insurance, and the government makes sure that there's no tiers there. In other words, you can't, I guess technically you could go out and buy extra services, but for all intents and purposes, there's a single level of care given to all citizens, but it's provided by a private system, not a government-owned system. And my own argument would be that government provision of healthcare is inherently inefficient. You want people competing for care because competition improves quality, but you don't want to pay for care. You want to pay for care at a fair but reasonable rate, and you want coverage for everyone. So I think you could look at Japan, you could look at Taiwan, you could look at South Korea. All these systems were based on the American system, but what they all have in common is a national health insurance.
Yes, and I think in some of those countries, don't they also have private health insurance if you want it, but it's not for profit. It is not for profit health insurance, as opposed to Cigna and Humana and Anthem and the kind of stuff that we have in this country where the CEOs are making $20 or $30 million a year.
When you talk about health insurance, that's really where a tremendous amount of waste is occurring, right? Because if you're looking at it objectively, that's another 10 or 15%. We know that the loss ratios of most health insurance companies, it's ironic to me they call them loss ratios, but it's the amount they pay for direct medical expenses.
They call it a medical loss ratio, which is what they're paying. What's what they pay? They're paying for what they're selling.
Yes, but that loss ratio, if it gets above 85%, they go crazy. So that documents to me right there that 15%, of Medicare billing under the traditional Medicare is 2 or 3%.
And Taiwan is less than 3%.
Yeah. So I think there's 10% savings, which would be billions of dollars right there. But the problem is that politically people don't want to give up their private health insurance unless they are forced to. So I think you've got a tremendous inertia. They tried to go to a single care system during 2010, and it was they proposed it, but it just wouldn't go. So once again, I think there's going to have to be a crisis to precipitate it.
But what about having private insurance that's not for profit, like
Yes,
it used to
exactly.
be? Like Blue Cross Blue Shield used to be not for profit, and if the excess money either went back to increasing better care or decreasing premiums. Yeah, it's my understanding in Germany that all the insurance is not for profit, and you have a choice of which company you want to go with, but you're not paying extra money that's going to stockholders.
That could, once again, I think anything is possible with intelligent design, and with a clean sheet of paper, we could probably work all of this out. But I know that it was called, during the Clinton administration, they tried to have a discussion about it. It failed. I think during Obama's administration, they tried to have a discussion and it failed. So I think we're just going to have to keep, fighting the good fight. But the one thing I do know is a crisis is coming, right? I just read something yesterday that said that by 2050, 61% of Americans will have some kind of significant heart disease. that's a combination of aging and sedentary lifestyles and all of that. So not only is the population aging out and living longer, there's more people on government insurance, but on top of that, there's also declining health status. So a cataclysmic crisis of the system running out of money is going to occur. I'm 100% confident of that. I just can't tell you when that's going to happen.
Well, let me give you an example of how a not-for-profit system has worked very well. Louisville, the University of Louisville Hospital was run for a period of time. The board of directors, the board of trustees of the university, in its wisdom, hired Humana to run it for a while, and that was a nightmare from hell. They just used they used the Charity Care Trust to run the hospital and sucked as much money out as they possibly could in any other way. They just did nothing to actually benefit, to improve the facilities, the staffing. And then, in its wisdom, the Board of Trustees hired Columbia HCA to run the hospital, which was another nightmare from hell. And then they hired a company called Catholic Health Initiatives, which is a not-for-profit company from Denver. They went bankrupt. There was U of L, there was the Jewish hospital system, and there was a whole bunch of hospitals. There was a psychiatric hospital, there were peripheral hospitals, there was a Louisville General Hospital, the University of Louisville Hospital. The last university president, to her credit, before she left, put together a plan that acquired, they got money from the state and from two Jewish foundations, about $150 million. They put this all together. This is a not-profit system that has incorporated all of the private practitioners that were in the Jewish hospital system, and it is doing so well that it is building an extension on the hospital based upon the resources that they've acquired from running the system as a not-for-profit and putting the money back into the system as opposed to giving it to overpaid CEOs, political contributions, and investors. And it works. I mean, I talked to Kelly about this the other day. I mean, they really have done an outstanding job, and they've got money. The money that comes in doesn't go out somewhere else. It stays in the system.
Yeah, I think they've done an incredible job in doing that. And the people of Louisville and the state of Kentucky need to be really knowledgeable of that and thankful for all that.
Don, before we end, I want to thank you for your wisdom, and I hope we can get you back again. We'll find something else to talk about. I think you've got a great understanding of what's going on, and one of the things that we do here is we're to some extent we're preaching to the choir. Gene and I are physicians. A lot of the guests we come on are physicians, and it's good to have an administrator comes on and kind of give us a balance that we need with some of our ideas. Gene?
I had one final question. One of the favorite concepts of for-profit health companies now is value-based health care. Don, do you know anything about that? And is there any legitimate role for this concept of value-based health care?
Yeah, I do think that there's a role for that. The big issue for healthcare through the years has been fee-for-service and how fee-for-service gives the providers incentives if they are for-profit minded. It gives the fee-for-service, the more things you do, the more the more fees you get. So these concepts have been around for 30 and 40 years of different types of value-based care. But you have to have value-based standards in place, because if you do a capitated, because we're really talking about capitated payment versus fee-for-service payment. So if you don't have quality standards in place, it makes it eliminates the temptation to cut corners. And for example, the federal government has required doctors to use these HEDIS measures for many years, since 2016. And there's a carrot and stick. There's extra payment that comes in if they do these quality improvement activities. On the other hand, there's also penalties if they fail to do them. But they are basic tenets of medicine. Some of the doctors from a previous generation would argue that we would do this anyway. It's good patient care. But these days, it's not a bad idea to have some of these quality systems in place. And I looked this up in preparation for the meeting, and looks like there's about 15 physician quality measures that are currently being used for the Medicare program.
That sounds good, Don, but our group and our movement has found lots of things not to like about these programs. In terms of there are more systems there to go by, and that adds administrative cost. Who's going to check on these people that are checking off, and where the accountability comes in for people who've actually said that they have followed these procedures?
Well, aren't all these things done by for-profit health insurance companies now? The value-based care,
Yes.
The Medicare Advantage. I mean, I didn't realize that this was self-inflicted by Medicare, that they've hired the for-profit insurance companies to execute these programs, and they make money out of it.
Yes.
Humana is about to do nothing but Medicare Advantage.
They're already doing it.
Oh, they?
Yeah, you get, even the employees for Humana do not have Humana insurance. They can go outside and buy. So Humana is nothing but Advantage Care and Medicaid.
I didn't know that. Incredible.
Yeah, I think it's like everything. I mean, should you have quality standards for physician practices and for hospitals? Yes. The deals and the details of how these programs are managed, and whether they're managed by for-profit companies that have that have a chance to make excess profits. I think we probably can't talk about that anymore today because we're kind of running out of time. But should there be quality standards for physician practices and for hospitals? I would say yes.
Oh, absolutely. No question. Don, thanks again. You're great. We'll do it again.
Well, I'd like to thank everyone, including our listeners who joined us today, and I hope you'll tune in next time. Thank you.